Ladies and gentlemen, welcome again. It's a new podcast. As usual, we try to bring the best people on stage or to the studio. Again, we have Dr. Basma AlRowaily. She's going to introduce herself and we're going to discuss a different subject today. We're going to discuss hormone replacement therapy. Stay with us. Stay tuned. Welcome, Dr. Basma.
Ahlan. Thank you, Danny, for hosting me. So I'm a family physician with the Canadian Fellowship of Family Medicine and Anti-Aging Regenerative Medicine from University of Florida. And I hold also certification in aesthetic medicine. So whenever we're talking about women's health, it's my passion. And whenever we do aesthetic procedure, I address the hormone replacement for my patients.
Okay, I'll start with the beginning. Mm-hmm. What is menopause? How do you define menopause?
Mm-hmm. So menopause is actually the depletion of the ovarian hormones. By the time a woman hits 30 years of age, she has only 10% of her eggs in the ovaries. So as time goes by, we know that there's a time where she's going to have some symptoms of depletion of those hormones in the form of hot flashes, in the form of insomnia or difficulty sleeping, mood swings, joint aches and pains, dryness in the skin, dryness in the eye, cognitive impairment. So these are the symptoms of menopause, and it is due to hormone depletions that are produced by the ovary.
Uh-huh. In case of menopause, you recommend to start the hormone replacement therapy, right? If I'm not mistaken.
We do, actually. When women come to us and they complain of symptoms, or even I educate women, and before menopause, there's an area which is called perimenopause, which is the start of the depletion, and it starts with depletion of progesterone. And at that time, specifically, women start having changes in their sleep. They will have headache that they've never experienced before. They will be irritable, and they'll start having some edema and bloating. So and irregularity in their menstrual cycles. So they might have a heavy period, they might skip the period, they might have scanty period, and this is all perimenopause, and it's progesterone deficiency.
Dr. Basma, what are the symptoms of menopause?
So you can think of it from head to toe. First of all, your hair is going to be brittle and dull and dry. Your memory, your concentration, your cognitive ability are going to be impaired. You're going to have insomnia and problem sleeping. Your mood is going to be affected. You might be depressed, you might be anxious. The eyes are going to get dry, the skin is going to be dry, you're going to have more wrinkles, you're going to have aches in your bones and joints. There's going to be increase in the bad cholesterol. You're going to be at risk of cardiovascular disease. You're going to have visceral fat. You're going to have a risk for type 2 diabetes, increased triglycerides. You're going to have osteoporosis. You will have dryness in the vagina. You will be at risk of recurrent urinary tract infections. So the list goes on and on and on.
All the menopausal women, they experience all these symptoms, or is it part of these symptoms?
The most important symptom that they present with is actually the hot flashes, and this disrupt their sleep and disrupt their well-being and their ability to function. So it's the hot flashes. This is the most common presenting symptoms, and the rest of the symptoms, it could be they will take it as part of aging, or something that like to have an achy joint, a frozen shoulder, a recurrent urine infection as something normal. It wouldn't occur to them that this is because of the depletion of their hormones. So not all women will present with all symptoms, but a big majority of the women will have most of these symptoms.
Oh. I was going to ask, what is the therapy about?
Unfortunately, most of the physicians will put the women on a SSRI or an antidepressant, and I tend to always educate my patient that this is absolutely normal for the amount of progesterone that you are having. They are depleted in progesterone, and once you put them either on a cyclical luteal phase progesterone or a continuous progesterone, they improve tremendously. So please, ladies, don't rush into using an antidepressant in your late 40s or early 50s, because definitely you're not depressed.
How is the therapy given? Like, how is it done? Is it injections? How is it done?
No, but it's usually a hormone replacement therapy from the name. It's an estrogen progesterone replacement therapy. Just like when you lose your thyroid function, for example, we replace the thyroxine. If I'm losing my estrogen progesterone, I'm going to replace it in a form. Of course, the safest way now is to give it through a transdermal, either in a patch or in a cream. So you bypass the liver and you reduce a lot of the side effects that was linked to hormone replacement therapy.
Now that you spoke about side effects, does this therapy has any side effects? Considerable ones?
There is no nothing in medicine that doesn't have a side effect. If you take a Panadol, you will have some people will have some side effect with it. The side effects are minimal, and if you weigh the benefit compared to the risk or the side effect, then you will see that even the guidelines have changed towards encouraging women, if they don't have an absolute contraindication, to start using hormone replacement therapy. The side effects, of course, would be with someone who was chosen wrongly to start a hormone replacement therapy. It could cause endometrial hyperplasia or thickening of the lining of the endometrium in the uterus if it has been given in a wrong dosage, or it hasn't been followed up with a transvaginal ultrasound. Sometimes it can put the lady at a risk of a thromboembolic, a venous thromboembolism, if it's an obese patient, if it's a patient who's smoking, consumes a lot of alcohol, leads a sedentary lifestyle, going on a flight for like 16 hours without moving.
Okay.
So these are relative contraindications, and again, they are minimum, especially with the transdermal. If she's taking an oral estrogen, of course, her risk is going to be high.
I see. And what about the risks from the therapy? Are there any risks?
Well, this is what we're saying. If someone has a predisposition for breast cancer, for example, a BRCA gene with an estrogen positive receptor, of course, she's not going to be a candidate for estrogen replacement therapy. But basically, the benefits outweigh the risk by far.
Any clinical cases where you do not recommend this therapy?
We usually have, in the past, there was maybe 14 or 15 contraindications, and since 2012, the International Menopause Society changed them or reduced them to maybe 4 or 5. So someone who has a vaginal bleeding that hasn't been diagnosed or worked up, you will not put her on HRT. Someone who has a personal history of breast cancer or endometrial cancer will not be a candidate for HRT. Someone who has a liver disease, because you need your liver to detoxify these hormones, will not be placed on an HRT. Someone who has a personal history of thromboembolic phenomena will not be a candidate. So basically, these are the only contraindications.
Other than that, they should go on an HRT.
Of course, but we do it in a professional way. We screen the women before we start the hormone replacement therapy. We make sure that they have a normal mammogram, they have a normal pelvic ultrasound with normal ovaries and a normal uterus. If they have a large fibroid, we will not start, because it will make the fibroid even larger. So we do a liver function. We make sure that their cholesterol and lipids is done, their diabetes. So we do full screening, full evaluation to make sure that there are no contraindications or risks when we start the women on a hormone replacement therapy. And we start with like a baby dose and transdermal. The recommendations used to say 5 years, but they've changed it now, and they can continue for 10 years after menopause. And the earlier they start, the better it is for their bones and for their overall well-being.
Dr. Basma, your advice for women who are menopausal but don't know if they should go through this therapy or not, HRT, your advice to them?
find a physician who's comfortable with hormone replacement therapy, because the barrier actually to putting women on hormone replacement is the fear from the doctor's side. Since 2002, when a large study, it was called the Women Health Initiative, was published, and they produced these like data or results. Since then, most of us, including myself, we stopped using hormone replacement therapy. But for physicians, and until now, some physicians are reluctant to start. So find yourself someone who's up to date, who knows the evidence behind hormone replacement therapy, who is in women's health, who is interested in women's health. I really get frustrated when a woman comes to me and she said, my gynecologist advised me against them, or my gynecologist say you just have to deal with the hot flashes, or you're going to have osteoporosis, you're going to have cognitive impairment, you're going to live a very impaired life because of the implication of deficiency of the ovarian hormone. So please do your own homework and find a physician who's up to date with the hormone replacement therapy. And always, when you're doing your follow-ups, there should be no risks, because you're always going to be screened, or you're going to be checked on routine basis to make sure that you are benefiting and not getting any side effects from the HRT.
So these ladies, you recommend that they should explore always the possibility of going through the HRT,
For sure.
hormone replacement therapy.
For sure.
Thank you very much,
You're
Dr.
welcome.
Basma, for
You're
the
welcome.
valuable information and advices you have given us today in this podcast. Ladies and gentlemen, stay always tuned for more podcasts with the best physicians, doctors, and healthcare professionals. See you.